together is 2023 first town hall. We have several town halls, 6 town halls altogether this month during Family Empowerment Month, culminating in a first time in-person Family Empowerment Day since 2020. So we're excited to have the entire month of March be our Family Empowerment Month, where we will replicate the town halls that we've done over the past several years that have been so successful that we decided to keep them in addition to doing our in-person Family Empowerment Day. So I'm pleased to have our first Addiction and Recovery Town Hall is the first one. And tomorrow we have at 3 p.m. the Mental Health Town Hall. And so we hope you'll join us for that one as well. So our panelists today, we have 3 panelists that are joining us. And then we have ambassadors who will be asking questions. For those of you who've joined town halls in the past, you know that we have panelists that represent the state agency and the chairs of the committees in the Assembly and the Senate who represent that particular issue in today's town hall about addiction recovery. And then we also will have people who are ambassadors who will be asking questions, people with lived experience, youth and family members who have questions that they've prepared for the panelists so that everyone in our network has an opportunity to hear directly from legislators and state agency folks, as well as from young people and family members who have direct lived experience. So again, welcome to everyone. And it's my pleasure to be able to introduce the panelists today. And I'm going to ask each of them to just say very briefly who they are and what their role is and what brings them to this town hall today. And then we'll turn it over to Barbara Callahan, who's going to facilitate the questions from our ambassadors. So first we have Maria Morris-Groves from the OASAS office. Maria, do you want to introduce yourself?
Good afternoon, everybody. As Paige said, my name is Maria Morris-Groves. I have the privilege of being the team lead and the director of Adolescent Women and Family Services at the State Office for Addiction Services and Support. Thank you for having me.
Thanks, Maria. We've been working with Maria for decades and have had the opportunity to work directly with her on a lot of things related to children and families within the OASAS office. Next, we're pleased to introduce Assemblymember Phil Steck, who has been the chair in the Assembly and graciously has agreed to answer questions today for us. Assemblymember, do you want to introduce yourself?
Yes, I represent, my district is now about 85% suburban, town of Colony, town of Niskayuna, town of Guilderland, and a little bit of the city of Schenectady, and I'm chair of the Assembly Committee on Alcoholism and Substance Abuse.
Thank you, Assemblymember. And I don't see the Senator Nathalia Fernandez, who is the new chair in the Senate, is also going to be joining us, but I don't see her on the screen yet. So we're going to go ahead and get started. And when the senator joins, Barbara, if we could just pause to let her introduce herself.
Perfect. So good morning. My name is Barbara Callahan. I work for Families Together. I've worked with them for 22 years. And I'd like to introduce first Stephanie Marcasano from Westchester, who will talk about things that are happening in Westchester. Stephanie?
Thank you so much, Barbara. That was a quick intro. And thank you, Paige, and everyone at Families Together for your continued support of our work. It's always a pleasure to collaborate with you and to bring questions to the table. I was delighted to be here last year, and I'm looking forward to once again seeing Assemblymember Steck and hopefully meeting Senator Fernandez and seeing the OASAS representation as well. So I asked a question at last year's Addiction and Recovery Town Hall regarding integration and the critical need for the creation of a single agency to address co-occurring mental health and substance use disorders. For those who don't know me, I started a nonprofit called the Harris Project after my 19-year-old son died by accidental overdose in 2013. Harris had both mental health and substance substance use disorders. So I've been a big proponent for a single agency in New York State. So last year we had a single agency bill that passed in the New York State Senate and the introduction of a single agency bill in the New York State Assembly by Assemblymember Anna Kells at the end of the 2022 session. Unfortunately, it seems this year that there hasn't really been much of a legislative commitment to this. Yet in 2023, we've really come to understand how nearly all of our youth and families in these systems have all sorts of cross systems experiences. The evidence is conclusive that integrated treatment for co-occurring disorders, not sequential treatment going here first for your substance use, and then when it resolves, going somewhere else for mental health, or simultaneous treatment, doing them both at the same time, but in different places, that's not really how people best heal. So while OASAS and OMH continue to highlight efforts towards integration, in practice, services truly remain silo. And this is antithetical to what is needed for prevention through recovery. There's now a new partnership for integrated care that has representation from the 3 largest trade associations in the state. I sit on the Opioid Settlement Fund Advisory Board, where we've recommended and the state's approved an overarching theme of co-occurring competency and a commitment to integrated care. So my question is, if not now, when? I know that there's talk about a single license, but 2 agencies interpreting even the same written document can lead itself to a whole host of complications. So my question is, how can we truly accomplish the goal of supporting the delivery of integrated services without truly integrating the administrations? Thank you so much.
And Cheryl Williams from Long Island is also here to speak. Cheryl?
Good afternoon, everyone. My
Barbara,
name is
hold on.
Cheryl.
I'm
You
sorry.
might want to let
You
the
wanna
folks
wait for
answer the
some-
question.
Apologize. Yes. Assemblyman Phil Steck, Maria. Do you have a response?
Well, as Ms. Marquesano well knows, I am opposed to the merger concept. Even though I agree with everything she says, I don't think the merger gets us there. There are serious problems in OMH. One thing in OMH that is a serious problem is the lack of any provisions for intermediate care for people with mental health, serious mental health disorders. What typically happens is you go into a hospital bed, which the governor proposes to expand those. Then you're there for 72 hours, depending on the person. You would be released, you wander around. In my experience in the city of Albany or the city of Schenectady, and you're either, depending on your inclinations, you get involved in substance abuse again or criminal activity, and you're picked up by the police and taken to another mental health facility like CDPC. And then if you're lucky, you go again to a different hospital that might provide you with some additional treatment. Then you might go out, because OASAS does supervise these programs, to a 30-day substance abuse program, or perhaps if you're really fortunate, you might go to a 90-day program. Now, of course, when our celebrities have drug and mental health issues, they go for 6 months or for a year, because it takes a lot of work to address these issues. So then when you come out, if you don't have a substance abuse and your problem is just mental health, pretty much either way, you're going to go into supportive housing, because the way OMH wants you to do this is to go into supportive housing and get into outpatient treatment. A lot of folks who have mental health issues are not ready for outpatient treatment. They used to have 30-day housing for people to get mental health treatment. OMH abandoned that in the guise of wanting people to be more independent. So, and at the last budget hearing, the chair of mental hygiene, Aileen Gunther, and I both agreed on the need for what we call intermediate care for people with mental health serious mental health problems. And they are, those services are not being provided by OMH or being allowed to be provided by others at this time. We have proposed the state operates 12 addiction treatment centers that are 30-day programs. I have legislation that we could transform these into centers for treatment of co-occurring disorders. On the not-for-profit side, the governor's budget does call for a streamlined licensure proposal, as Ms. Marquisano noted, but the governor doesn't support the merger concept. The prior governor did, but the prior governor did because he always wanted to reduce spending on everything, which is why we are in the mess we are in now. So I give this governor a lot of credit for wanting to invest in mental health, but the problem is some of those investments will not be successful because of the lack of intermediate care and the idea being perpetuated that people are still going from the hospital bed to a supportive housing and outpatient care. So that's where we are on that issue.
So
Yeah.
my
Stephanie, I'm
follow-up-
going to give you a chance. Yes, go on.
So I'm somewhat confused by the focus solely on people who are hospitalized as opposed to the vast majority of people with co-occurring disorders who are kind of in the in-between space. In that Article 31 clinics, for example, on the OMH side are now required to use medication for opioid use disorder, and there are quality improvement projects in that space. Yet there are remaining challenges with how agencies can bill. There are differences in how an OASAS agency or provider is billing, what the length of a session looks like, how family supportive services and their treatment on their own can be integrated in. And so I'm somewhat baffled by kind of taking the most extreme scenario and looking at how to create hospital beds that can do both, when quite frankly, celebrities get 6 months of treatment and it's not evidence-based and it's not the right treatment. And so they're no more successful than my son was. I mean, we have once a week individual integrated treatment in Westchester County that I got funded for privately that allows a completely different paradigm to be infused. Yet it's much easier for our OMH providers to do Encompass than it is for our OASAS providers because they're built on a group model and their billing systems are different.
Yes.
And so I think that what this continues to come down to is the people who are experts in this are probably housed in the community at large, people like me, advocates, other people in the state that are doing the work on the provider and organization side within the two agencies themselves. Yet this stranglehold on no single agency is not allowing an opportunity for a collaborative process to build the system that we all need.
Well, according to the governor's office, their emphasis on the community mental health centers will do that. That's their position.
And right now, the mental health providers, the satellite clinics in our high schools in Westchester County are now moving out providers who only do mental health because they need integrated co-occurring. You've got the Cannabis Control Board that has not spent $1 on prevention upfront. They are not co-branding mental health and substance use messaging for our young people. Our young people most at risk for cannabis use disorder have emerging and existing mental health disorders. We are continuing to perpetuate this vision that this belongs here and that belongs there when these are the same individuals and families.
Well, I certainly don't agree that that's what we should be doing, but I do not agree with you that the single agency, which would take 10 years to implement, is the right answer to the problem. I think Governor Cuomo supported it because he wanted to use it as a vehicle for cutting funding. Clearly, sometimes people have to agree to disagree.
Well, there's a lot of lives at stake, so I think that there's more than just agreeing.
Well, that's why I'm trying to have an immediate solution by converting, at least for the people who could get immediate services there, the 30-day addiction treatment centers immediately converted to centers for co-occurring disorders. That doesn't necessarily help the not-for-profit community because those are state-run facilities, but that is an immediate step, and the governor's budget has taken a direction with respect to a streamlined licensure proposal. So no one is denying the need for co-occurring care. The difference is how to get there. Now, as to the comment being made, I just want to reiterate this, that the reason there's an emphasis on the people who go to the hospital and then out, most people with severe mental health crises do end up in the hospital, at least initially, if they're in severe crisis. The state is establishing 24-hour crisis stabilization centers for mental health and substance abuse crises. I particularly don't see the value in that because it's too short a time period based on the experience that we've had for it to be effective. And by the way, there's always this supposition that legislators don't have any personal experience in this area, and I can tell you that supposition is false.
So Assemblyman Steck, I'd like to just take a minute to answer it as well. Recently, I was on a call with a young man who was 17 years old that we were looking for co-occurring treatment for inpatient. He was really doing very poorly in his mental health, and we were looking for something. And so I said to the folks who were looking, I said, the gold standard is to be dual diagnosis program, right? That's the gold standard. And what I was told was, we're just lucky to get a bed. We're just lucky to get a bed. That is after 10, anywhere, absolutely anywhere, whether it was in
get a bed or they didn't get a bed.
He wound up getting a bed in a local hospital for him to stabilize, and then he was set back out on the street again. However, had he been in a co-occurring, had he been in a co-occurring facility, he would have then been taught,
Correct. That's why.
So
that's why we're trying to convert the 12 ATCs immediately. That could be done immediately in this budget.
Hunter, who's over?
Centers for Treatment of Co-occurring Disorders. It doesn't solve the whole issue. It doesn't make it universally available. That is true, but it is a significant step forward and would have addressed the situation that you're talking about.
So I see the senator has just joined us, but before she introduces herself, Stephanie, I would like to follow up with you on the Encompass and the billing issues you may be having with our providers, partially because technically they bill the same APG rates. So it may just be an explanation thing. I don't know that for sure, but I'm more than happy to follow up on that question. And Barb, I'm just kind of curious to have an offline conversation about the case you were talking about, because the RRSYs may have been an answer for them with a little bit of prompting. So again,
let me just interject one thing.
Please feel free to follow up.
Will do. Thank you.
Propose at the suggestion of one of the organizations that came to our office that there be an enhanced billing rate for agencies that are treating the co-occurring. We did propose that. I makes perfect sense. But, the budget, it's kind of a difficult proposition sometimes because I've been a long advocate for increasing revenue. What tends to happen in budgets is that in order to fix one problem, you got to take it from somewhere else. Now, I would have no problem taking a massive amount of funding and eliminating all the corporate subsidies in the New York State budget and dealing with this issue. That's not going to happen because there isn't a consensus for that. And there are a few of us who would support doing that, but that wouldn't be supported by the majority because people seem to believe in these corporate subsidies, even though they're demonstrable failures. But so it's not like there hasn't been attention paid to the lack of appropriate payment.
But Assembly member, there's so much money that's going in down the OMH side, and there's not one word about substance use there. And then you look at the Opioid Settlement Fund Advisory Board and how we've overlaid co-occurring on every single recommendation, yet there are still challenges with how the RFA process is going, how agencies are demonstrating a commitment to co-occurring disorders. And so I continue to see multiple pathways of funding, yet no integration. I hear conversations about the prevention prevention programming and the language that's being used and the fact that it's not co-branded and people saying on the OASAS side that OMH doesn't care about prevention because you can't prevent a mental health disorder, but you can prevent co-occurring disorders by empowering our young people to understand the relationship. To me, it's antithetical to think that we're going to keep being able to move this forward. We look, even when you're talking about the hospital 30-day stays, whose oversight is it?
No, we're not talking about
The
hospitals.
paradigm that's
No,
being
we're
used.
not
I mean,
talking about hospitals. That we
So
are not
I
talking
wanna make
about a
sure-
30-day hospital stay. Nope.
I want to be mindful of time because I want to make sure that we get to the other questions. And also Senator Nathalia Fernandez has joined us, and I just want to say welcome as the new
Sorry, she
chair.
walked in on this.
I know, but it's important. I mean, this is not new information for her, even though she's new to this chairmanship. I just welcome you, Senator, and appreciate your willingness to be here with our group today. As you know, Families Together represents families and young people with lived experience in multiple systems, including addiction and recovery, and including mental health, as we were just talking about. And our philosophy is nothing about us without us, meaning that these people on this screen, as people with lived experience, have an expertise that is crucial to the success of any policymaking that happens, because our experience gives us the opportunity to be able to share with policymakers and policy implementers the experiences that we have and the things that we know can and cannot work for our families and for ourselves as young people. So we welcome you, Senator, and I just want to give you a second to introduce yourself, and then we're going to go on to the next question and turn it back over to Barbara.
Thanks,
Well,
Paige.
thank you so much. I'm so sorry for jumping in late. It's really the craziest time ever. And excuse me, being a chair definitely has its many hats and responsibilities. But this is a position I'm so honored to have, one that I care deeply about. And, you know, having these conversations are really important for me to be the best chair that I can. You know, I know we all want more money as it comes to budget time, but it's really important to fight for what we really, really need. And I know that there is a greater need this year, as we just see the numbers are terrible. We see that they're going up in every avenue, from alcoholism to substance abuse to opioid addiction. And it's really a critical time. So I do want to thank everyone in this call and in the work that you do. And, you know, even before I got to this position, for being the strong advocates that you are, to making sure that we're helping everybody that is affected by substance use disorder and their mental health needs, aside from just the individual that is going through, because this does affect children and families and, you know, the network that the people have around them. So when it comes to this budget, I mean, I'm there. I know that we have a decrease we saw in $240 something million that they're saying came from a pot of money that's just not there anymore. I'm really trying to push to just keep the total funding that we had, because I think it's such a disservice and a disgrace that we're even just getting a proposal of that much less money. I know there's conversations about I guess the possible merger, but intertwining of services, because a lot of the I guess the root causes and then the remedies and the solutions that we fight for does. Oh, sorry, I was reading what you were writing. But it does come from both places, both agencies. You know, alcohol and substance use disorders could be rooted from a traumatic experience or a mental health crisis, and vice versa. So having those abilities to intertwine the services and care and conversations is really, really important. I think that the money that we got this year, the proposal of $1 billion to mental health, is a huge, great step. But again, like, where's the details? How is that money trickling down to the providers and to the services needed and the workforce that we need to strengthen? Because all this is great to talk about and great to imagine what we could do $1 billion. But if we don't have you, the people doing the work in this realm, then, you know, how are we really helping the cause? So I thank you again, and my ears are wide open, and, you know, my door is wide open to hearing the suggestions that you have for this budget, because, you know, for years I've been seeing how we want some things, we don't get it. Every year it's just a continual fight. I'm tired of the continual fight. Let's really just try to deliver and help this crisis where it's at. and stop it from growing.
Thank you so much, Senator, for your observation that things have not gotten better. I don't know that that's, necessarily common knowledge, but for us as family members, that is real. It has not gotten better. And people are still dying of overdoses. So thank you for your recognition of that. That's helpful to us to hear. I'd like to introduce Cheryl Williams from Long Island. She also would like to speak and from her point of view. Cheryl?
Good afternoon. Am I off? Good afternoon. My name is
Yep.
Cheryl Williams, Regional Parent Advisor for Families Together in New York State, and I'm actually in the Long Island region. But I also work with substance abuse committees. I'm on the subcommittee. I'm on the Drug and Alcohol Coalition in Deer Park. So I have 22 years of experience also with Families Together in New York State. But before I ask my question, I just want to support my colleagues that spoke before, and they actually spoke on the treatment for co-occurring disorders, because I do believe you can't treat part of a person. You have to treat the whole individual. So I support you in that. And I also thank Senator Assembly, Maria, for actually keeping it on the forefront as you move forward and never ever letting go. Let's work towards that. So as a parent who has stood with my child through addiction and recovery journey, which continues, because we know recovery is a lifelong process. I know that addiction impacts the entire family. We want to help our children heal, love them back to health. But the process is difficult, it's challenging, and sometimes isolating. No one should go through this alone. But for family members like myself, I feel there isn't a comprehensive strategy. I always have a problem with that comprehensive strategy for supporting families in New York. I have my child, it's on a daily basis. It's a challenge because that individual, like everyone gets up in the morning and it's okay, you go about your business. That individual has to be conscious every moment of not relapsing. And I know Assemblyman Steck, you kind of hit on that before, which I do appreciate, with going back into agencies, into treatment. So I do appreciate you recognizing that. So now can we speak to what the state will do to engage families so they can better support their loved ones in seeking recovery? I'm going to repeat the word engage families.
So,
And that's my question.
Cheryl, I'm happy to say that the New York Certification Board through ASAP will be offering scholarships for family peer support professionals, either SERPAs who want to work with families and need that credential, or for individuals who want to work that are family peers in the OMH system who want some information on addiction. Now, remember, a SERPA can work with family members. So a certified peer recovery advocate can work with family members without the F parenthetic. The F parenthetic is for those folks that want to be able to deliver family peer support services, specifically for the under 21 population as part of the Children's Family Peer Support Services. But I'm very excited to say that there are scholarships that are available. If not right now, they will be within a couple of weeks for folks that want to take that training. That's been a long time coming. And so I'm happy to say that that's happening. And very shortly after that, I'm going to jump ahead a little bit and say to Ashley, the youth peer scholarships will be available for that youth peer credential. And we're making it available for folks who work in both of the addiction service sector or the mental health sector, because at the end of the day, CFTSS services are the one model where we've really tried to integrate work. And by doing that, hopefully we can get a little bit better at our competencies across the board. The other piece that we did, Cheryl, prior to COVID, and we're in the process of looking at how we do better going forward, is we had rolled out the community reinforcement family training approach, which is really an evidence-based practice that looks at engaging loved ones who are concerned about someone's use. And that person doesn't have to be in services, because CRAFT looks to give the person both the support they may need for their own well-being, as well as skills to perhaps get the loved one into care. We are going to be doing some training, hopefully more training over the summer months on that. as well as speaking to one of the issues that Stephanie spoke of earlier, is sometimes providers use billing as a issue for trying to get to where we want them to be. So we're going to do some specific work with them around that. But CRAFT was specifically designed to help parents like you not feel so alone, to help develop some coping skills, to do some other, help you get perhaps your child or your loved one into care if they're not in treatment already. So we're going to really be putting a strong emphasis on that as we move forward. And then the last piece that I think is really important and exciting is under the CFTSS services, so the Children, Family Treatment and Support Services, we will have evidence-based practice rates probably in the next 6 to 9 months. And
Nice.
2 of those evidence-based practice rates will be specifically for family therapy evidence-based practices that can be used both with young people with co-occurring disorders, or either mental health or substance use disorders. So that is exciting to see that we're getting there. It's been a long time coming. I'm not going to say that there aren't going to be workforce issues, because I think we all know the crisis that we're in.
There is.
But I do believe that the fact that we've made a commitment to 2 evidence-based practices that are family-based, and that each system is really trying to bring family members to the table is progress. So I would say let's hope next year this time we're talking about what we've seen happen in terms of the implementation of those EBP rates and the training of staff to do the work.
Great,
Wow.
thank you.
Thank you, Senator Fernandez. It's exciting. Can you also put your family, what did you call it? Community reinforced family? What was
FAF.
it? FAF. Can you put that into the chat, please? Because I'm excited about that piece also.
I'll put the
And
link,
that was, go ahead, Maria.
I'll put the link in for, I don't know if there's necessarily a link, but I'll put in what CRAFT is. And
Thank you.
certainly you can follow up with Brad or Zach, and I can get you some additional information.
Great. I do appreciate that. So thank you so much. So we'll pass it on to folks. Senator Steck, do you have any comment on it? Assemblyman?
No, I have no comment.
Okay.
Thank you, Cheryl. And I'd like to introduce Ashley Dixon, who comes from Tompkins County. And your comments, please.
Thank you so much. My name is Ashley Dixon. My pronouns are they, them, theirs. I am the Collegiate Recovery Program Coordinator at Tompkins Cortland Community College in both Tompkins and Cortland counties. I am also the Special Populations Coalition Coordinator through the OASAS grant. And I am also a person in long-term recovery from substance use. For me, that means I have not had a drink or used an illicit substance since 2015. Over the course of my recovery journey, I know from experience that the onset of addiction starts at a really young age and is connected to early childhood trauma and unaddressed mental health challenges. When we think about prevention, we really need to shift our understanding. The domains of recovery, health, home, purpose, and community are also what will help prevent addiction in the first place. The spaces that children and young people spend their time in, like schools and college campuses, really need to cultivate those things so that we can thrive and heal and feel safe. So my question to you, as a person in recovery, a person in higher education, a person with family members who are, children in schools, is building a stronger youth behavioral health continuum, including youth peer support, part of our state's overall prevention strategy? And if so, how will the state sustain that in the future?
So I think it's fair to say that not enough is being done in this area. In the governor's budget, she proposes to invest a lot of money in charter schools, and I have said publicly that I feel that money should not be spent in that way, but should go in the area that you just spoke of.
Thank you, Senator Fernandez.
Well, yes, this is an obvious yes. We need to support our kids younger for their mental health needs, because before the pandemic, there was a lot of traumatic experiences happening, especially in underserved communities where, you know, gun violence is a normal thing. And it's been really heartbreaking to have those conversations with kids like, oh yeah, you know, just a shooting happened the other day. The guy at the store died. Like, that's not normal. That shouldn't be normal. And, you know, I don't think kids are able to understand their feelings, to process them in a healthy way. So yes, I definitely support funding for those services in our schools. I tried to do so when we got the federal grant, but there were some restrictions there. But we are speaking as loud as possible to help enforce those support services for our kids.
Maria, would you like to answer as well?
I think where youth peers are appropriate, we are promoting the use of them. I do believe that the SERPA parenthetic will be helpful for some services. And Ashley, you know that we're committed to kind of working through a health and wellness model for college campuses. And so we're continuing to do that, and we'll actually be having some conversations with OMH about how we can do some of that together. So Stephanie, I know it's not where you want us to be, but we really are, with every step of what we're doing, trying to think about how do we integrate. And on the kids side, that has always been our goal, is to not argue over what comes first, but to make sure that the youth in our state have the services they need. And so it's not without challenges, but we continue to strive to make it a better system.
So I guess I'm last but not least. And, you know, I think I've been doing this for over 22 years, but my son passed away in 2010. And many of the same things that happened in 2010 are still happening today. Children are not getting the dual diagnosed treatment that they need. My son, we went back and forth to Four Winds multiple times. And then when the addiction started, it was like, no, you need to go someplace else to do something about that addiction. And, you know, come back when you need, when that's over. As though that was something we could do, as though that was so that we could compartmentalize this in a way that said, okay, this is here, fix this, come back here. I know you've all heard this before, but the reality of that, right? The reality of that doesn't necessarily hit you because it's all words. But for me, it was real. For me, it was, how do I find people who want to do both of these things, right? How do I save my son's life? Because I know what he needs. And it seems crazy to me that the people who are serving me would not know that, right? That the social workers that we'd worked with for years did not know that. That the system in some way was split up into two separate directions, and never we were going to mix the two. And so whether you merge or you don't merge is not necessarily my issue. My issue is, how do I move forward to save my child's life when I have needs in both places? I'm going to belabor this for one more minute. If I had a son who had cancer and only, right, you're smiling, and only hospital special surgery was available, how would that possibly work? How would that work? Right? We never would say, if a person had a stroke, that, oh, we're only going to take care of this piece, not this piece. It just isn't the way things should be. And this is 10 years ago. And I can tell you that it was even prior to 10 years ago, right? So, and our numbers have not gotten better. So to Stephanie's discussion about how we do this, or whether we should or we shouldn't, tell me how it's going to look different tomorrow, because we don't have another 10 years. I've got grandchildren.
Yeah, I wanted to raise a point here, and maybe Barbara, you can provide some insight on this, because I certainly don't know the answer. A lot of psychiatrists, and this has nothing to do with OMH, OASAS, this is psychiatry. They will say they cannot diagnose mental illness. And now there may be other psychiatrists who disagree, but there are a lot of psychiatrists, including the head of the psychiatric outpatient program at Albany Medical Center, who take the position that you cannot truly diagnose mental illness unless a person is substance abuse free. This is not something that the state necessarily requires.
So in truth, that's, for us, for Stephanie, for myself, our children entered the system in mental health. It wasn't a matter of deciding whether or not they had a mental health diagnosis or not. They came in with trauma. They came in with a mental health diagnosis. We're not trying to diagnose it at the time that they're using substances. That's already a foregone conclusion. And so I think you're wrong in thinking that, just because they have a substance abuse, you can't diagnose the mental illness piece.
I wasn't saying
it was
I
there
felt
beforehand.
that way.
And-
I'm just reporting what I've been told by leading psychiatrists. We may disagree with them. There may be other psychiatrists who take a different position.
I highly disagree.
I don't know. I would say also that there are a lot of folks who get into the system through substance abuse. And when they go into a OASAS facility or program rather, and they are diagnosed with something of a mental health nature that is more serious than anything OASAS run programs are prepared to deal with, they are sent out. That's the infamous primary diagnosis approach, which is not medical. It's not scientific. It's bureaucratic. Nonetheless, the only point I'm making is that you do run into a lot of psychiatrists who are not being motivated by OMH, OASAS, or anything of the sort, who contend that if you have a substance abuse program, they cannot diagnose your mental health condition.
And none of that is rooted in evidence. That much of that is rooted in stigma and old-fashioned beliefs. And when you
So how do you change this?
I'm also a data person, and so if you look at even how
do you change the psychiatrists from approaching it?
I've been on panels with many psychiatrists who even say that I understand the numbers on co-occurring when I say that 70% of people who are who have substance use disorder have a co-occurring mental health disorder. They will say it's more like between 90 and 95%. And so it is completely contrary to I've sat on panels with the head of
agree with that entire premise.
But the data is, Assemblyman,
how do you
the data really
change the minds of these psychiatrists
by relying on the evidence, by saying, you wouldn't say that some quack person who says that you only need chemotherapy for cancer and no radiation, that's what you're going to go with because they say it. You can say it emphatically. What the data suggests, and I'm going to even suggest that you look at the NISBA study, which is not really, that survey is not really my favorite place to be, but I'm going to tell you that right now in this country, there are 645,000 young people with major depressive disorder and co-occurring substance use disorder. Do you know how many of them get treatment for both? I'm not even saying integrated treatment for both. 0.9%. 6,000 young people in this nation get what they need. So just because a psychiatrist says that you need to figure it out does not make it right, because
So what's the proposal to change the psychiatrists from
Oh, you know what? They can spend some time with Dr. Paula Riggs, who's developed a SAMHSA-approved integrated treatment modality for teens and transitional.
What's the proposal? I understand that you're 100% convinced that the science is different, but my question is different than that. My question is, assuming you're correct.
Yes.
We're going to assume you're correct. So I think you are. So I assume you're correct. The question is, how do we change the opinion of psychiatrists? I would say, at least in my experience, the psychiatrists I have encountered take the position, and I think that's what Barbara was running into, that you have to be free of substance abuse in order to have a mental health condition diagnosed. That's their position.
So my suggestion for New York State would be a quality improvement project with those providers across the state, many of whom have CCBHCs and either have federal funding or block funding to actually enhance their integrated work, allow them to be the leaders and do the education that needs to happen. The 6 agencies that are doing Encompass in Westchester County, their prescribers were required to partake in the training so that that they understood that A, you could prescribe medication for mental health disorders, even when people are substance involved. B, that there's medication for opioid use disorder that sometimes should be onboarded even for those 18 and under, and that there are ways to do this that are evidence-based. I mean, I will say in the prevention space, much to Ashley's point, a lot of that is innovative best practices, promising practices. In the space of integrated care for co-occurring disorders, there is a lot of evidence on how to deliver those service models.
Okay, so on the one hand, unfortunately, we cannot direct psychiatrists or psychologists on how to practice, in the case of psychiatrist, medicine. We can't do that. But what we can do, and if you could provide me with information that could make this possible, we could mandate a continuing education course for psychiatrists, say, or psychologists in the treatment of co-occurring disorders. We could mandate that. And what
Except
that,
for the few you spoke to, most of them are going to say, we know that. It's not a surprise.
well, they don't say that where I live. I'm telling you.
And
So that's that.
Ashley from our
So
panel
can-
also wanted to ask a question. Ashley, do you want to?
Weigh in, thank you.
Thank you. I mostly just kind of wanted to follow up and respond to Assemblyman Steck in terms of psychiatrists and psychologists, and I understand, of course, when we're looking at OMH and OASAS, the importance of a diagnosis in terms of treating somebody can be very important. But I also want to call back a little bit to what Stephanie and Barbara have said about the importance of prevention and starting really early and getting in there with not necessarily needing a diagnosis to start giving people the treatment that they need to get better. It's something Tompkins County just recently integrated mental health with whole health is what they call it now. So it's physical health and mental health together. We have a PROS program, which is a dual diagnosis program that is incredibly well attended. I really do support the idea of requiring continued education on all sectors. Like that should just be required in general. It's also an important part of when I do SERPA training. I am also the best practice trainer. I don't know if I said this earlier for certified recovery peer advocates, and not even specifically saying that this needs to be in schools. It should absolutely start in schools. It should continue in colleges. But even for adults, this idea that we have to have a diagnosis of a substance use disorder and a diagnosis of major depressive disorder in order to give people the holistic treatment they need. We don't need either of those. Frankly, we need people who can meet folks where they're at and get them started on a path where they can be substance free or where they can be stable enough to receive the substance treatment, the substance use treatment that they need. I know Maria raised her hand, so I want to let her speak.
Thank you.
But thank you. I just wanted to add that.
Thank you, Ashley. That's helpful. Good.
Just a couple of things that I thought the group might be interested in is one, there has been an expansion in Child Health Plus to include the CFTSS services. So that doesn't, again, you know, I've been with many of you for many years, so we know where the challenges are, but I think that's a very real opportunity for many young people that we didn't have until recently. So that's really good news. And then on April 1st, our residential rehabilitation services for youth will also become part of the Child Health Plus benefit package. And so again, really good news that that's another service that's accessible to more people across the state. And lastly, the comment I wanted to make, Assemblyman, when you were talking about how do we educate physicians or psychiatrists, it is the same way that we educate the drug court judges and other folks. And it's by listening to the family members and the folks in recovery with lived experience at the table. And I say that because I recently got a phone call from a colleague and a friend who talked about her son who had experienced co-occurring disorders since adolescence, being able to successfully complete their drug court experience. And she was given an opportunity to speak in front of the judge. And the judge is a firm believer that people have to hit bottom. And she was able to say to them, I couldn't let him hit bottom. I needed to advocate for him. And you were the safety net that has helped me save his life. And so I think there is a very real value to listening to the people around the table with the lived experience. And sadly, Assemblyman, I would agree with you. Oftentimes, many of us come to the table, maybe not initially with that lived experience, but sadly find it somewhere along the line. So many of us are allies with lived experience, but I really do think that some of it is continually in all of our environments, having the conversations to alleviate the stigma. I think the other tool that is in the toolbox when it comes to addressing co-occurring disorders now is we can talk about harm reduction, and we can talk about introducing the idea of how do we keep people safe. And that is something that 10 years ago, Barbara, we didn't know and we couldn't say publicly. So I think those are things that are positive stances toward the path of where we want to be. So I'm going to stop because I know we're getting close to time, and say thank you for inviting OASAS to the table. It's always a pleasure, and I really do value all of you and continue in our work that we will continue to do together.
And Maria, thank you for always inviting families to the table. We really appreciate it. And as a closing statement, I just want to make that, this has 10 years. We have not brought down the numbers, Assemblyman Steck. So somehow we have to make some changes here. So, again, whether it's a merger or no merger, or whether psychiatrists believe one thing or they don't believe something, that's not the point. Individual psychiatrists should not rule the world, right? Should not change the system, nor should it be that we change the system, other than to say that we've experienced this. We've been down this road, right? For me, I would say that a lifesaver would have been that somebody would have absolutely allowed him into Four Winds and addressed both those issues. Both those issues were something we needed to save his life. So, and I think that Stephanie could say the same thing. And we've lost children in this, so we're pretty educated. But thank you very much for your participation. I very greatly appreciate it. Ashley, Stephanie, Cheryl, my peeps.
Thank you, everyone,
Paige.
for participating. Very, very much appreciated. And I encourage everyone to join our mental health town hall tomorrow, and to check out our website for the other town halls that we have the rest of this month, and to join us on the 21st of March for our Family Empowerment Day. Maria, I want to say thank you so much for bringing up the Child Health Plus issue. That was something that we worked on because we know that service, CFTSS services, including family and youth peer support, are so crucial and should be available to more than just Medicaid eligible families and young people. And Brad, I wondered if you could just talk quickly about, beyond just Medicaid and Child Health Plus, the work that we're doing in public policy to help further that.
Yeah, so Child Health Plus, CFTS services being available to Child Health Plus families is a huge advancement towards that in-between no man's land of private insurance and Medicaid. A lot of the services that we know are helpful to families that are available through Medicaid are now available through CHIP, and we need to extend that to commercial insurance as well. We have a few strategies for that. Some of these things we're seeing in the context of school, that the governor has proposed some new ideas around requiring commercial insurers to cover school-based mental health clinic, and we're wondering why not go further than that? Why not extend that to everything that commercial insurance fails to cover? And beyond that, for supporting family and youth peer support specifically, we have a $5.5 million ask for non-Medicaid flexible funding so that the existing family and youth peer support apparatus can grow and serve more families until we meet that gold standard of commercial insurance actually covering everything that families and young people need. So $5.5 million would be flexible funding. That could be equivalent of 3,000 to 4,000 additional families. Or 120 new full-time equivalents in the youth peer support space and family peer advocates. So those are some of the things that we're going to be talking about. We appreciate so much of your time and energy that you brought to this today, and you'll continue to hear from us. Please see us as partners in this work. Thanks, everybody.
Thank you, Assemblyman, and thank you, Maria, and thank you to all of our panelists, and thank you for everyone who joined today.